Hello, my name is Vicki Hudson, and I'm going to be your guide and moderator today. Thank you for joining our educational program entitled The Thoracic Oncology Nurse Practitioner's Role in Patients Living with Small Cell Lung Cancer and Lambert-Eaton Myasthenic Syndrome. This program is sponsored by Catalyst Pharmaceuticals. Please see the Catalyst Pharmaceuticals disclosure statement. Within this first module, Beth Sandy, a nurse practitioner from the Abramson Cancer Center at the University of Pennsylvania, will explore paraneoplastic neurologic syndromes. Good to have you here today, Beth.
Thank you, Vicki. I'm glad to be here today. These are my disclosures.
Thank you so much.
So let's talk about paraneoplastic neurologic syndromes. Paraneoplastic neurologic syndromes are generally immune-mediated disorders that can occur in patients with cancer. And because we use immunotherapy in our patients with lung cancer, this can be problematic, and it's good to know about. About 10% of small cell lung cancer patients may develop a paraneoplastic syndrome. These symptoms may become apparent prior to even being diagnosed with the cancer. Detection of paraneoplastic syndromes can lead to early cancer screenings and early intervention for a tumor. So when these symptoms are present before the cancer diagnosis, it may help us diagnose patients earlier. Earlier diagnosis and treatment may improve patient clinical outcomes. So let's talk about some of these paraneoplastic neurologic syndromes in small cell lung cancer. The most common one that we see is Lambert-Eaton Myasthenic syndrome, or LEMS, and this occurs in about 3% of patients with small cell lung cancer. The rest are also listed here and occur in about 1% or less of patients. Lambert-Eaton Myasthenic syndrome is a rare immune-mediated disorder affecting the neuromuscular junction. It's characterized by muscle weakness, autonomic dysfunction, and areflexia, which is a loss of reflexes. About 50 to 60% of LEMS cases are associated with an underlying cancer, most commonly small cell lung cancer. The median age of onset in LEMS in patients with small cell lung cancer is about 60 years, which is a little bit younger than our average age of lung cancer, which is between 68 and 70 years old. Greater than 67% of patients with LEMS and small cell are men. 67% of cases with LEMS that are co-occurring with cancer are in patients with small cell lung cancer. You see about 10% in patients with lymphoma, leukemia, or thymoma, and then the rest are a myriad of other different types of cancers, some with adenocarcinoma. But by far the most common cases of LEMS that occur in cancer are in patients with small cell lung cancer. LEMS is a rare neuromuscular disorder that's often undiagnosed or misdiagnosed. Greater than 90% of LEMS in small cell lung cancer is actually undiagnosed. And then a lot of times it's actually misdiagnosed. 58% of LEMS cases are actually misdiagnosed. And we talked about that in the beginning for my patient with small cell lung cancer, who it took me a while to figure out why he was having such lower extremity weakness.
And now let's take a brief look at a video explaining the mechanism of disease for LEMS.
Control of muscle movement depends on input from the nervous system. The neuromuscular junction is the main site of this coordinated activity, relaying action potential signals from motor neurons to muscle fibers. Normal neuromuscular functioning requires appropriate transmission of acetylcholine at neuromuscular junctions. When an action potential reaches the axon terminal of the presynaptic motor neuron, acetylcholine is released into the neuromuscular junction. Acetylcholine binds to and activates acetylcholine receptors on the postsynaptic muscle fiber. Sufficient acetylcholine signaling initiates a sequence of events that results in muscle contraction. The action potential-mediated release of acetylcholine relies on the coordinated action of voltage-gated calcium channels and voltage-gated potassium channels. During normal neuromuscular transmission, an action potential causes a wave of depolarization as it travels down the presynaptic motor neuron. Presynaptic voltage-gated calcium channels open in response to the depolarization, allowing an influx of calcium. Increased intracellular calcium signals vesicles to fuse with the presynaptic membrane and release acetylcholine across the neuromuscular junction. Significant depolarization causes voltage-gated potassium channels to open and efflux potassium, repolarizing the presynaptic neuron. repolarization leads to the closure of voltage-gated calcium channels, ultimately terminating the action potential and preventing further acetylcholine release until the next action potential. Patients with Lambert-Eaton myasthenic syndrome, or LEMS, have reduced neuromuscular signaling due to the presence of autoantibodies directed against voltage-gated calcium channels in the presynaptic motor neuron. These autoantibodies impair calcium influx during an action potential. Reduced intracellular calcium limits presynaptic vesicle fusion and release of acetylcholine across the neuromuscular junction. However, presynaptic stores of acetylcholine and the postsynaptic response to acetylcholine remain intact. Disrupted acetylcholine transmission reduces activation of acetylcholine receptors on the muscle fiber. Patients with LEMS experience diminished muscle fiber contraction and muscle weakness due to reduced acetylcholine transmission. Neuronal repolarization due to potassium efflux occurs as normal, ending the action potential before sufficient acetylcholine has been released.
So LEMS is progressive and debilitating. So as you can see on these Kaplan-Meier curves here, the orange curve is the patients who have LEMS and small cell lung cancer, and the blue indicates patients who have LEMS with no small cell lung cancer. And so you can see that the LEMS associated with small cell lung cancer tends to be more severe and progresses more quickly than a LEMS that's not associated with small cell lung cancer. And so that makes our diagnosis and treatment of this really important for the patient's clinical outcomes. You know, you can see that the leg weakness is pretty much the same for both, whether it's LEMS with small cell or LEMS without small cell. So we can see here in the overall survival with the Kaplan-Meier curves that for patients with extensive stage small cell lung cancer, the solid line is the patients who have both extensive stage small cell and LEMS, as opposed to the dotted line represents the overall survival for just the run-of-the-mill extensive stage small cell lung cancer. So they clearly do much better if they actually have LEMS on top of the extensive stage small cell lung cancer. The same goes for patients with limited stage small cell lung cancer, where if they have LEMS associated with that as well, they have an improved overall survival versus the dotted line here showing the patients who just have limited stage small cell lung cancer without the LEMS associated.
Thank you, Beth. As you heard, LEMS is a rare neuromuscular disorder that is often undiagnosed or misdiagnosed, which makes awareness absolutely critical. Paraneoplastic neurologic syndromes may be rare, but understanding their signs, particularly with underlying cancers, can lead to earlier detection and better outcomes. Thank you again for your attention and your commitment to advancing patient care.